best in the world at? What are they deeply passionate about? And what will society continue to pay family physicians to do? So these are 3 questions that I'm going to walk through over the course of this talk. Now this talk came out of 2 experiences that I had almost back to back. Last July, I went to a presentation by a gentleman named Tim Hoff, who is a sociologist in the business school at Northeastern University. And his research for the last 10 or so years has been studying family doctors. Who knew? And he talked on this topic. Then a couple months later, I came here and heard a lot of innovative things. And I started putting stuff together. Now, for those of you who were at the last meeting here in September, a couple things that I took home with me was this idea of patient guides, which was brand new to me. We talked about machine translator in exam rooms, and we just had an example of that in the first talk. Another group was using iPad for COPD patients, and I started putting these ideas together and started thinking about, okay, what does the future hold for primary care, specifically family medicine? Now, a little bit about Tim Hoff's book. This is the book he wrote based on a study of about, I think he said 115 family doctors, qualitative study. It's called The Next in Line, Lowered Care Expectations in the Age of Retail and Value-Based Health. So after he talked, I read this book and really liked it. I was really quite surprised by a lot of topics that he covered in here that came out of his research. Now, there's a lot, I mean, it's 50,000 words. I'm going to show you about 100 words. A lot of things I like from what he said. He says, running a primary care practice today means being efficient and streamlining the delivery of services in whatever ways possible. And that, I'm guessing, is familiar to everybody. It's what we've talked about also so far today. But then he goes on to say, keeping individuals away from face-to-face visits with the doctor is often the implicit goal. That sound familiar? That is a stated goal in my institution, that 70% of patient contact will not be with a physician. But this is team-based care, right? Another way to say this is team-based care. Then he goes on to say, relationships are hard to quantify, multidimensional in substance, consisting of psychological and behavioral features, and require extended periods of time to cultivate and assess. Everybody agree with that? Yep. So, how are we going to do those 2? How are we going to keep patients away from doctors and have relationships develop? And that's where I started to come together with some of these ideas. The last thing he says is trust is perhaps most central to the doctor-patient relationship. At least on both sides. He interviewed about 115 family doctors and a lot of their patients. And this is where they came up with. Now, what do these people have in common? We've got a Walmart greeter, the pilot who flew me here today, and a physician working at American Family Care. They're all people. Good. Can we drill down a little bit? They're all service industry. Good. They all work for organizations for which we do not have a relationship with individuals. We have a relationship with the organization. So this gentleman is the face of Walmart. But people go to Walmart because of what they expect of Walmart, not what they expect of him. I don't know who actually flew the plane this morning, but I knew it was JetBlue, and a high likelihood they're going to get me there, maybe even on time, which they did. Same thing. When you need I don't know if you have this in this area, they're all over Boston, American Family Care, urgent care centers. When you go to an urgent care center, you don't go to see a specific physician, you go to see somebody American Family Care. And then again, this is the movement that what he's talking about, retail-based care. This is, I'm in Boston, I didn't say it at the beginning, I'm in Boston, and all of our hospital institutions are working on brand identification so that people will go to Mass General Hospital, not Dr. Smith at Mass General Hospital, Mass General Hospital, or Cambridge Health Alliance, which is where I'm at. We all put our trust, the goal is we put our trust in these organizations, not in the people. So the whole goal moving forward in medicine is to develop relationships, not within people, the people within organizations. So I teach, so I have to have objectives. The three things I'm going to talk about is I'm going to explain the concept of de-skilling and how that's going to, I see, maybe change the way practice is performed. Talk about how technology, I'm actually going to build on a lot of concepts that have already been talked about today. How we're going to move, patient expectations are going to move and change because of technology. And I'm going to get back to this hedgehog concept in just a second. So, we've already talked about this a little bit. The big three are getting into healthcare. Joe mentioned earlier, what's it called? Heaven? Haven.
Safe. It's like a safe haven.
Safe haven. Yeah, I thought the similarity to heaven was something too, but I'm sure they paid a lot of money to come up with that word. Anyway, we know that Amazon with the Tuguande is going to come into healthcare, and they're saying we're just going to take care of our own people. We all know that is the pilot. Apple is getting into healthcare. Mike Evans is a family doctor who's at the University of Toronto, was the chair of the University of Toronto for a long time. He's been working for Apple for 3 or 4 years. He said when he got to Apple, Apple is late into this business. He said when I got there were 10 people in healthcare. Now there are 600. 600 people devoted just to healthcare. And then we also talked about Google. Big three are going into. Now what do they all bring to healthcare? The first thing is going to be obvious. They bring big data, right? That's what they do. They know more about us than I do. Than each of us does. I swear, I start thinking about something and Google pops it up for me before I even type anything. So they manage an incredible amount of data. But what's less obvious, and it goes back to what I was talking about with Walmart, JetBlue, or AFC, is they also have relationships with people. There are Apple people out there, right? I see some. I'm an Apple person. All right, we bring them into our homes. Anybody have this? This? Internet of Things, right? You have to figure out what the top one's about. But I was at a neighbor's house yesterday because we're going to redo our kitchen, and they have a Bluetooth-enabled hood, a vent over their oven. Why do you need to be Bluetooth? I don't know. I said, what do you use it for? We don't know. But it's Bluetooth, so it's got to be cool. Anything's better with Bluetooth, right? Anyway, we've got technology. We've got these people in our houses. Mike was telling me over lunch that worldwide, every day, about 1,500 people say the word suicide, hey Siri, and then they say something about suicide or killing. 1,500 people. He says, now a lot of those are, hey Siri, go kill yourself. And they've got a snap. Is that mine? That's a plant over there at my desk. 1,500 people. Some of those are contemplating it. They want to figure out how they can do that because they're in the house and they can maybe make an intervention. We're all tapped into nutrition. I have MyFitnessPal on that phone that just spoke to us. We can track how people buy food. We can track their activity, right? Here's the obvious ones. Anybody have any of these on your wrist? I see one. Yep. Okay, good. But what other ways can we track data? The nice people Lyft know that I got up in time to get on in a Lyft at 5:45 this morning. So somebody knows that I was up probably at 5 o'clock this morning, which I was. So these are all ways that we can be tracked. And now you start taking all of these and put them together. You put that together with social media, which is, Mark Zuckerberg is carefully looking at all of us. And we start getting a lot of data from social media. And what if we started pulling all of that together? And we've got 3 groups that know how to do that. Then, as we talked about this morning with Epic and Nuance, is we can have processes that can read emotions using voice stress analysis in the moment. These are done when you call customer service various places. They will read in the moment your stress level and see if it changes based on customer service. We can do facial analysis in the moment, right? Because that phone that just talked to us, I just hold it up and it says, oh, it's you, Alan, I'm going to turn myself on. And there are over 20 web-based apps that can recognize emotion. So again, you start pulling this all together, all of a sudden we've got a tremendous amount of data, and we can go to Google and say, Google, I'm sick. Because Google's already in our office. We've already talked about a couple of these. There's lots of tools that are available for people to diagnose and treat themselves. Here's just a couple. We talked about Google and predicting heart disease, suicide prevention tools. You can do a urinalysis on your iPhone. Don't pee on your iPhone, but you pee into it, and then you stick the thing in. Here's some more Mayo Clinic looking at patients who have distinct voice features. Apple Watch can do anything. Google is getting into this. Everybody is looking at this. You can do cognitive behavioral therapy with the best named software in the world, Wobot. You can monitor and diagnose your own moles. This is a dermatoscope that fits onto your iPhone. There's been a lot of discussion about Apple Watches and their ability to pick up AFib or not. Right now, you can set this on your own Apple Watches so that if you happen to fall and you don't get up, it will ask you, are you okay? And if not, it will automatically send a message, whoever you program into. Monitoring and diagnosing autism. What's this one? Health screening and emotion. So we start pulling all of this together. The question is, where do we fit into all of this? Oh, here's just a couple more. Apple Watch. I have an Apple Watch, so I'm always looking for these things. Not that I want any of them. I'm just curious as to where they're going. So the concept here is what Tim Hawk, well, a lot of people call it, but Tim Hawk first introduced the topic to me in his book. It's called de-skilling, which is you take people-based skills and replace them with technology. So I want to show you how that might happen in the world by giving you a case. This is a case, now I put it 5 years out, maybe it's 10 years, maybe it's 2 years, I don't know. It's totally made up, but I'm just imagining how it might happen. So imagine you're seeing a 54-year-old woman with diabetes. She could have been managed at home with Amazon Health, which doesn't yet exist, but likely will soon. Anything with an asterisk doesn't exist yet, except in my mind. But for some reason, she's asked to see you. She's asked to come in. But before she's seen you, she's already seen one of those patient guides that I heard about last September. A member of your care team has already spent about 15 minutes with her, collecting information, answering her questions, and reviewing this information. I couldn't do the graphics, but we saw some of the graphics in Dr. Berber's presentation, the very first on the wall. I can imagine that certainly happening. Embedded in technology in the room has been reading her facial expressions and body language, has analyzed her voice for stress, and has performed a semantic analysis of how she is actually saying things. And that all is becoming available to you. But you can't just, if you got hit with all that information, it would be like a fire hose blasting you. So there has to be an interface here, which is what we talked about this morning, which is artificial intelligence that organizes it all for us. So here's what I imagine might happen. This is my picture of an iPad. This is in your handout if you want to look at it. But this might be a patient data summary that you would get. Now, remember, you haven't said anything to the patient yet. But you can tell what her diet is based on how she orders food. It's 60% carbs, 30% fat, 20% protein. We know what her activity is. She walks 3.6 miles per day. She sits for 11.7 hours. She has her social predictors of health we can do by looking at her email traffic, her browser history, social media platform, demographic and personal information. We can find out where she is. Active medical issues. Well, we have type 2 diabetes. She's overweight. But the algorithm says that she's not actually going to be able to lose, by population averages, as much as she needs to lose. She's recently quit smoking. By probability, she is, what did I have her? Perimenopausal. And she has that mole, what's it called? Mole monitor, the dermatoscope on. She has a mole on her thigh, which she actually won't tell you about. But that's her main reason for coming in. Here's her psychic stress that is analyzed through AI using all of this stuff, including in-the-moment semantic and facial analysis. Her psychic stress is moderately high. We've got some percentages of why that is. It's maybe because of sleep, because her pillow tells you how well she sleeps. She has this health concern because she keeps checking the mole monitor. You can tell by her email stream that she is increasing her discussion, or she's emailing her daughters more. Maybe that's a source of psychic stress. She's already done the PHQ-9 at home, and you already have that information. And because of her browser history, you know she's been looking up moles a lot. So you know all this, you haven't said anything to her. Then it tells you, I call it the odd tool, a little nod to Gwande. You know, for those of you old enough to remember, at the end of the very last episode of MASH, Hawkeye says, "I just want to go home and get the people of Crabapple Cove to say ah." So this is also a nod to him. So you have 7 minutes to, again, I made this all up. You have to, first of all, you have to develop a relationship. Now, you've never met her before, so how are you going to do that? Well, we happen to have, you can mentor her daughters, and we can put up a picture on the screen of her. How are they doing? You can mention a recent vacation, which you know about through Facebook, because the computer has brought it up. You can tap and say, "Oh, how was Cancun?" or wherever. It will. It's creepy, but it's all possible.
But it's not trust.
It's not trust. Well, no, because you haven't used the intermittent trust builder. Step 1. Click for options. Asterisk doesn't exist yet. Empathy needs. What are her empathy needs? Well, she needs a high interest, low compassion, use standard active listening techniques. Agenda setting. Stated reason for visit is diabetes. Likely unstated reason for visit, mole, 24% likelihood of inquiry, probably at the door. Oh, by the way, can you take a look at this? Unstated needs, weight loss, continued smoking cessation, support she needs. She's only been non-smoker for 2 weeks, or 2 months, and psychic stress. Here's AI-generated pathways. Here's what you need to do with the mole. Tell her the phone app results, and maybe even look at it, just tell her it looks fine. Diabetes, here's some things you can do. Smoking cessation, here's what you can do. Again, this is before you ever talk to her. So, don't shoot the messenger. I don't necessarily agree with this. I just was thinking, based on these 2 things that I've been exposed to, and a quick Google search of all things health, health apps and stuff, all the possibilities that could happen over time, over in the short time, when these 3 big players really get into the business. In the last presentation, we talked about transformation. This is disruption. This is disruption from without, not from within. We've been talking about how do we disrupt from within. These people are going to come in. Mike says that at Apple, he's called old man because he's in his 50s. And there is nobody over 25 that works with him. And so they don't have any tradition. They have needs. They have YouTube, email, social media, video game needs that have to be met, which all have characteristics of instant gratification, but not necessarily relationships. They have relationships, but they're virtual and they're not built on. So the question is, how do we develop relationships with people who already assume we have a relationship with them? So how are you going to ask all those questions you normally ask? Because they're going to say, why are you asking me that? It's all up on the board. How are you going to develop a relationship in these times when you only have, again, I just totally made up, but when you only have 7 minutes to conduct that visit? So this is the idea of the hedgehog concept. Hedgehog concept is an old Greek idea that a fox has lots of different tools, lots of different ways of finding prey. The hedgehog only does one thing, and it does one thing very well. When it gets attacked or is afraid, it rolls up in a ball. That's all it does. And it just sits there until the fox goes away. So Jim Collins, in a book called Good to Great, talked about in business, every business has to figure out their hedgehog concept. What is it they do better? What are they passionate about? And what will people pay them to do? And that is the hedgehog concept. So that's just out of his book. So our question is, what is medicine's one big thing? And this is the provocative part. What is the big thing? We've had Keystone Conference, we've had a lot of conferences of what we can do. But with this pressure, I see two pressures to the profession right now. One is technology that I just talked about. And then there's a whole other group of people who are trying to disrupt using different practice models. From within direct primary care, but also minute clinics and internet-based visits, all sorts of things. So what are we best at the world at? What are we deeply passionate about? And what will society continue to pay for? So, and I don't have any answers. So that's where we are.